Hey guys, I'm Jennifer Briggs and I'm one of the senior residents here at the OSU Emergency Medicine Residency Program. I've got a lecture for you that I teamed up with Dr. Bree Ropke to make. It's toxicology for your COMAT review. Dr. Ropke, how are you doing today?
Not bad, Jennifer. Thanks for having me. This is, hopefully we'll cover most of the talks that you need to know for COMAT, but please give us feedback after you take your test and let us know, what we did well and what we could include if we don't have it in this lecture, and we're going to be happy to help and edit because we're here. We're really just making these essentially to help you with your COMAT. So,
yeah. So if you guys find something on the test that strikes you that you're like, I've never heard of that, it failed me, just email us, let us know, and we will certainly improvise and improve for next year. So the topic today, we're just going to kind of go over some broad ingestions and exposures. It's not all inclusive like she mentioned, but some of it will be pills, like prescription drugs that you can get, recreational drugs, you'll see like, cocaine, methamphetamine, alcohols, as well as environmental exposures.
Yeah, and poison control, that's there for kind of all of us. I have 4 kids, and I've unfortunately had to call a couple times from home. I give great information, but one of the things that we actually do in our training is go spend time and do a toxicology month, and that you're kind of on the other end of this when people call about these ingestions. And so this is something that we do when we have someone with that comes in for an overdose or an accidental ingestion, and they give you a lot of good information, and they're very helpful, and it's good for documentation, and it's good to kind of help give you ideas of how to help take care of your patient essentially. So
sure.
Good.
So we'll just go ahead and jump right in. We'll start with the case. We've got a 76-year-old that comes in by ambulance from the nursing home for altered mental status. When you do a quick doorway exam before you go and actually lay your hands on the patient, you see that they're clinically dry, and they've got some weird intermittent jerking motions, and their belly looks distended. The nurse hands you the medication list from the nursing home while you're standing there, and you see on it that they're on oxybutynin and diphenhydramine, as well as some other just kind of run-of-the-mill routine meds. Dr. Ropke, what do you think about this so far?
Goodness, altered patient. We have a few things we think about when we have someone that's confused. They could be septic. I'm always going to think of sepsis when I have a 76-year-old female, or a patient in general, that comes in and they're febrile and they're tachycardic. But then, you always need to think about tox in these patients too. And so I have a dry patient that's altered. I know her finger stick is normal, so she's not hypoglycemic. I'm going to look at the med list, and I see some things that could cause this also. So one of the things that it could be is an anticholinergic toxidrome.
Yeah. So there's kind of a classic presentation they get, and it's the hot as a hare, blind as a bat, dry as a bone, mad as a hatter. And so you'll see that they'll kind of fit this toxidrome. They don't have to have all those features, but they often have several.
Mm-hmm.
If they've got urinary retention, a slow GI motility, their belly's full of air, and their bladder's full of water, and so you'll see that kind of contributes to the abdominal distension.
Yeah, a lot of antihistamines. So sometimes this is important why we always review med lists with patients, really, because you could be the one to give that extra antihistamine, and they're already on like a TCA, and they're already on these medications for their bladder, and then you're like, yeah, go home and take some Benadryl, and then that was just the extra medication that causes this toxidrome. So it's not always purposeful. A lot of times these are accidental and just from poly-ingestion, and you have a lot of anticholinergic properties in different drugs.
For sure. One of the things I just want to point out, when I took my test, I was not prepared to have to answer questions about plants. And I saw something kind of like this. What do you think that is, Dr. Ropke?
Well, I know what it is because I have the answer. The issue is I too missed this question. I'm like, why are they giving me a picture of a flower? And so, yeah, this is Jimson weed. and I'm pretty sure that I'm like Lily of the Valley, which is not an anticholinergic medication. That's actually cardioglycoside. So yeah. They will throw pictures of flowers at you, and it's a good idea to be able to identify these. And it's awesome if you're like, yep, I know what that is. But as otherwise, you're like, why are they throwing a picture of a flower at me? So. Another thing, so antidote-wise, is physostigmine. That is the test answer for this, but it doesn't work truly how an antidote does. It's kind of more hey, this person's altered. This kind of answers my question. I give them physostigmine, and then they become completely normal for like a short period of time. And you're like, they're an anticholinergic toxidrome. But generally, we're more supportive care for them. So.
Yeah, for sure.
And I'm always going to work up the altered older patient or just altered febrile patient for sepsis too. You know, that's something, unfortunately, on our end where we don't get cultures and everything back in time to know, you know, if that's the cause or if it's a, you know, ingestion. So
yeah, make sure it's really not organic.
Yeah. So now we have a 16-year-old that comes in by EMS, and they're altered, and they just had a seizure. No history of seizures. They have an empty prescription pill bottle present and a suicide note that's on the nightstand. Their blood pressure is 86/70, heart rate is 130, respiratory rate is 26, O2 sats are 95% on 2 liters, temp is 37.6, and their finger stick is 120. What do you think about this one, Jennifer?
Well, first off, they sound kind of sick. You know, their blood pressure is 86/70, and they're tachycardic. They also have had a first-time seizure. When you listen to the history, it sounds like maybe an intentional ingestion with the history of the suicide note, so I'm worried about a toxidrome here as well. Conveniently, we have an EKG, like we're getting our safety net set up. Anytime somebody has kind of unstable vitals, you make sure you're getting your IVs, get them on the monitor. A nurse comes and hands me this, and I'm going to be kind of keyed into a few things. I see that in AVR, that top lead there, looks like there's a terminal R wave that's present, which is an unusual feature, especially in the setting of the widened QRS. I see that they're tachycardic. When you kind of look at it, you can count the little red boxes, and so counting over, it looks like their heart rate is between 100 and 150. So each little, counting over, I wish I had a mouse for you. Looks like, so like here would be, over to here it's like 300, and then 150, and then over here would be about 100. Kind of a cheat way that we can go over in person later if you want, just ask whoever you're on shift with. But so they're tachy. They've got a wide QRS, and then they've got a terminal R wave and AVR, and so that makes me really suspicious for a TCA overdose.
And unfortunately, before you get this figured out, they decompensate, and now this is what you have.
So one thing to just kind of point out on this is, like, so now we know this is tox lecture, and so obviously we're going to be thinking about toxidromes here. But if somebody just hands you this EKG, the other thing to be thinking about is hyperkalemia. You've got a really wide QRS complex. We're physicians. We have to think about the whole picture, not just tox, but also organic etiologies for things. So just kind of memorize this and know that that's red flags.
So we have a TCA ingestion, and if you're lucky, when we get these patients by ambulance or a family member brings someone in, because they're worried about them, if you take a good history and they're like, hey, I brought the bottle and here's the empty bottle and they're on amitriptyline, awesome, that takes a lot of the hard work out of it. But unfortunately, a lot of people don't come in with the answers for us. So we kind of talked about things that cue us into this being a TCA overdose or ingestion. And so what we really are going to do besides our safety net, because, in emergency medicine, it's always your primary survey and your secondary survey. So we establish a safety net with bilateral large bore peripheral IVs. We put them on the monitor, and then it's ABCs. So we look at airway. We're going to intubate if we need to protect their airway. And so that's always what we do first. And in a lot of your questions, it's, hey, what's the first step? And so it's that safety net. But the answer for a TCA treatment is bicarb. And the only time you'll ever hear anyone in the emergency department yelling, we need more bicarb, is in a TCA ingestion. So how do you actually treat with bicarb? Like, what am I going to do with this patient?
So I like to have them, keep them just running on the monitor. So have the EKG there at bedside, just running a continuous rhythm strip. And as we're pushing the bicarb, kind of honestly as both diagnostic and therapeutic effect, we'll see that QRS will start to tighten up, and you'll see it drop below 120. And so that really confirms your suspicion that this is due to sodium channel blockade. And then you know that they need all the bicarb.
All of the bicarb. So once you see the QRS narrowing, it's when you can hang your drip. And you keep them on the monitor. The other thing with TCAs is, not only are they do they have sodium channel blockade, which is why you see that the EKG changes, but they also have antimuscarinic properties. alpha-adrenergic and GABA antagonism. So you also have your altered mental status and seizures, and they can be febrile. So this can be a hard one to diagnose if you don't have that whole backstory.
Sure. They can also be really sick. And so one thing to note is just, with the risk of seizure, they're kind of go into this really poor spiral where they'll seize, they'll get acidotic, and then you'll see their QRS widen, and they go into really bad dysrhythmias. And so they've got a pretty high mortality at about 15%. And so that's why, as medical students, we always want you guys to review that medication list and make sure that there's not something on there that could be contributing to their current clinical situation.
Yep.
So moving on, we've got a 56-year-old that comes in via an emergent EMS. He sounds like he's in respiratory distress. He's got a leaky nose, leaky eyes, his mouth, he's drooling, he's got muscles twitching. He sounds unwell.
He does sound unwell, and these are things that are like, shoot, I mean, he sounds like he's having a hard time breathing. He's in respiratory distress. Like, I need to go ahead and step in and take care of this guy's airway. But that would actually be a big no-no for me, because I could potentially get sick. And then if I'm having my staff all over him as well, doing all, establishing our safety net, they can also get sick. So what is this actually? Why don't we talk about the answer here?
Yeah. So, looks like on the image, looks like he's spraying. And so he's had some sort of exposure either to organophosphates or pesticides. They're, in kind of war type settings. There are some nerve gases that can cause similar effects, but it looks like he's got a cholinergic toxidrome.
So you actually want to decontaminate these patients. And we actually have a room where you're taking all their clothes off, getting them, sometimes what we say trauma naked, but we're getting them naked. We take them into this room where we decontaminate, and you're spraying them off. If it's a powder, you're not going to get that wet. You're going to get the powder off of them first. But in the case of a cholinergic, you got to decontaminate before you can go ahead and start treating them.
So whenever you're trying to remember what does this look like, there's a few mnemonics you can look at. There's dumbbells and sludge and the killer bees. And so basically the thing to remember is just if they're cholinergic, they're leaky. So they're having diarrhea. They're peeing all over everything. They've got secretions coming out of their mouth and their nose and their eyes, and they're sweaty. They look super unwell. The killer bees is kind of this triad that they can get where they've got increased bronchial secretions, they're profoundly bradycardic, and they're wheezy from bronchospasm. So in order to treat this, not only do we need to decontaminate and reduce or stop the exposure, but we need to give them atropine.
Mm-hmm. Lots of atropine. Now, I've never actually had a cholinergic patient on like organophosphate poisoning, but as a couple of our attendings will say is they use all of the atropine, and the hospital next to use atropine, and the other hospital's atropine. So sometimes it can take a lot because our final stopping point of treating these patients is, until the secretions stop. So you're drying up the secretions, and that's when you've treated these organophosphate or these cholinergic toxidromes. The other medication you can give, and I'm going to butcher this word, it's hard for me to say, pralidoxime or Tupam is the other thing that we call it. So that's the other medication that you can give in conjunction with atropine to dry these patients up.
Yeah. So the way, just in case you have a test question on it, the way that atropine works is it competitively antagonizes the acetylcholine muscarinic receptors. So basically it just works to decrease the parasympathetic input. So if you think about, a parasympathetic system, that's where the bradycardia is coming from. And so we're trying to block that with use of the atropine.
All right, so now we have a 25-year-old that comes in by EMS. They're confused and they're agitated, and we see handfuls of these patients every day. This is kind of like what we excel at, right? So they're diaphoretic, they're mad, they're agitated, they're delirious, they're throwing things at people. Police note drug paraphernalia on scene. They're hypertensive, they're tachycardic, they could be febrile. We always ask EMS what the finger stick was anytime we have someone that's altered. And so it's normal here. So this case is a sympathomimetic. So they're super sweaty. They're very agitated. PCP, oftentimes they're not wearing their clothes for whatever reason. and it's true. And it kind of just gives you this indication of what you're dealing with. But, unfortunately, we see a lot of methamphetamine use in our area, cocaine, PCP, and even, there's a lot of edibles that they're not feeling the effects of what they want to feel, and so they take a lot of, this edible of cannabinoid, and so they can present like this.
Sure. And you can't trust anyone. So people think that they come in and they took a certain something, and in reality it has been tampered with. And so like anything that's been synthetic, you have to worry about concomitant toxidromes. But these guys, just to kind of compare, because it sounds a little bit similar, they're tachycardic, they're hypertensive, they're hot, fever. And so whenever we kind of think back to the anticholinergic toxidrome, these patients are a little bit distinct because they are profusely sweating. So kind of just management for them, we'll give them some supportive care. If they are febrile greater than 39, we do need to consider doing some cooling. They can seize, and so, seizures or even just severe agitation, we just treat them with Ativan. It's very safe, benzodiazepine, calm them down a bit. Sometimes
they do require a lot of Ativan, and it's really just more like let it ride out, right? So you're giving the medication, you're keeping, as few people as you can, because they are very agitated, and so if you can have a calm room and maybe just like one nurse and one tech, but not a lot of people in the room, because that just kind of escalates things, and it could become dangerous, especially with PCP. They're very strong, and you'll see stories of like, they fight off like 5 police officers, or but it's just these toxidromes. The more that you can have less people in a calmer room, the better off that you and your patient will be. Just a bonus, the PCP, what is that? If I see someone's eyes kind of roving around, it's a bizarre thing to see in a clinical or physical exam finding, but what's that called again? It's some kind of weird rotatory nystagmus, right? So, and their eyes really are just kind of moving all over the place, like so that's kind of hey, I've done PCP, right? It's just yelling at you. So, just for bonus points there.
Okay, so now we've got a 72-year-old little GPA comes in by ambulance after family noticed that they were sleepy.
GPA. hard to wake up? Yeah.
I guess that he fell down recently, wasn't using his walker, and he broke his wrist. Somebody gave him some Norco. He's been taken on. Otherwise, they can't really give you much history.
All right. Well, I feel like you just gave me the answer. It sounds to me like he's had a little bit too many opiates. And so our EMS crews are really good at recognizing this and treating. But the family oftentimes, like, oh, grandpa's altered and they don't have this medication, which we're actually getting better at prescribing. But Narcan. So, we kind of we're trained, and we train you to, once we have that altered patient come in, the things we can think that we can rapidly reverse is like, you got to think of, maybe we give this patient Narcan, maybe they're hypoglycemic, or is their oxygen low, or are they an alcoholic and they need thiamine? So these are things that we, for every patient that's altered, we think about. And so this is one where, hey, I'm going to give Narcan to the patient. It's not going to hurt them, and it may fix a problem.
Yeah, absolutely. Yeah.
There's kind of a way to do this too. Yeah. If they're not breathing, when you're like, shoot, it's opiates, I'm going to give them a large dose of Narcan. Whereas, if they're just respiratory rates down a little bit, I don't want to completely reverse them, because then they became angry and then they go into withdrawal, and it's terrible. So, there's a way to do this the right way. But if it's to where they're unresponsive, we're going to give a larger dose.
There's also one other kind of unique setting whenever we consider using Narcan. And so, clonidine is a medication that a lot of adults take, and sometimes kids will find their way into this. And that can be a very life-threatening ingestion. And they come in kind of looking like they took some opiates, that's a limp, lethargic kiddo that's not really breathing. And so we treat it the same way. Even though it's not technically an opiate, it works on similar receptors, and so we're going to give them all of the Narcan.
Yep. All right. So now you have a 19-year-old that comes in, because this is tox day for you, Jennifer, and every case is a toxidrome. So they're vomiting, they look intoxicated, and because that you're like, I don't know that you're just drinking your everyday, alcohol, you get a bunch of labs because you're worried about this kiddo. He just doesn't look like your typical intoxicated patient, and you find that they have an elevated anion gap. They're acidotic, and they have acute renal failure. So what do you think about this case, Jennifer?
I think he definitely got into something that wasn't just straight alcohol. Kind of like you talked about before, we're always going to think about organic causes other than just, what seems to be at superficial level, like he got into, like some methanol or something of the sort. But if we're able to exclude all of that, then I would say that toxic alcohol is probably his most likely etiology. There's a few ways to get this, and unfortunately it's pretty cheap, and so we find a lot of people take advantage of this. It makes them, feel good, and it's affordable or just laying around, and so unfortunately it's got some really bad complications that can occur.
And honestly, with some, like, your kid gets into the garage and they, for some reason, get into the antifreeze and actually taste sweet. So these patients can be incredibly sick, and it can be a hard case to figure out unless they're like, hey, I couldn't afford it, and I drank all of the Germex, which I did have a case yesterday where the guy drank a bunch of Germex, and of the 3 ingestions, I'd preferred the Germex ingestion because they don't break. It breaks down to acetone, so it's the side, they're not going to go blind. They're not going to have renal failure from this. They may get gastritis. I can fix that pretty easily, and they just kind of have to write it out. But these other ingestions, can cause renal failure. The methanol, it breaks down to formic acid, and so that can actually cause like snow blindness, or it causes vision changes. So you'll have someone that comes in and says that they're also complaining about their vision changes, or they're seeing like snowballs in their vision, or it's whited out, and they also look intoxicated. So you need to consider methanol ingestion.
Did you know that places, I will not say states, but in regions where they make moonshine, they'll burn it over a fire, and if it burns with a blue flame, then that's how they know that it's like a tainted batch of moonshine, because it's got methanol in it, because methanol burns with a blue flame.
Huh. I didn't actually know that. I don't know what kind of state. I mean, it's actually pretty smart, because it would be a giant bummer to try someone's homemade moonshine and to come out with blindness on the other end. The other thing, too, and it's frustrating, and maybe I shouldn't mention it because this is just for testing purposes, but like if you suspect this, you treat it. Sometimes that little beautiful thing that you have to memorize, that sodium times 2 plus glucose divided by 18 plus, what is that formula? Like Winter's formula? No, that's not it.
Your osmolar gap.
It's osmolar gap, right? See, that's how I feel about any kind of equations that we memorize. But you do need to memorize this, and but at the end of the day, if you suspect this, you treat it. And how do I treat it?
So we're going to give them fomepizole.
Fomepizole. What if I don't have any?
Well, so there's a rumor going around you can just give them a beer.
Yeah, so you can give them alcohol. Beer. I read that some places you give vodka because it's higher alcohol content, and you don't have to give as much. So if you are out in the middle of nowhere and someone got into all of the antifreeze, and you don't have fomepizole, and it's a snowstorm, and you can't get them to the hospital that does have fomepizole, then you run to the nearest gas station and you get this patient vodka or a beer, and you give it to your patient. So,
which basically all we're doing with that, it sounds kind of backwards, but really all we're doing is we're trying to competitively inhibit that enzyme and prevent the formation of these toxic metabolites as your body, because it's all through alcohol dehydrogenase, and so we'd much rather that we were forming things like acetone or whatever alcohol breaks down into, than formic acid and oxalic acid. So those are the bad ones.
Right. So. All right. And then sometimes these patients are so sick that they even require hemodialysis. All right. So 33-year-old comes in and they are complaining of a headache and they're nauseous. And EMS actually tells you, like, it's super strange because the dog was vomiting. It was gross. There's dog vomit everywhere. It looks like the cat was even sick. And, you're like, I don't know why you're telling me this, but these are actually important things to clue you in to what we could be dealing with on this one. So what you think, Jennifer?
Well, I don't think that dogs and cats get the flu, so it makes me a little suspicious for carbon monoxide poisoning.
All right.
So on here, pretty simple. We're just going to give them oxygen, stick them on a non-rebreather. Even if you have empiric suspicion while you get your labs going, then just stick them on oxygen, because what we want to do is competitively displace that. And so, the risk of the free radicals for 10 minutes is going to be worth the benefit of getting that oxygen going. Kind of depending on the context of where the carbon monoxide poisoning comes from. Like we have a lot of people in Tulsa who don't use safe sources of heat, but if it actually is like a house fire or something burning, we've got to be worried about concomitant cyanide toxicity. And so that's, one of those things where we've got some other medications that we would use for that. But
yeah, and I mean, I've never had this patient. I hear like if you have cyanide toxicity and it's that, you're dying on the scene, and that's why fire actually has a kit to treat these patients. So, I think they generally give that once they pull someone out of the fire. And they also have fancy tools of knowing like the levels as well.
Yeah.
So,
yeah. So there's a few things that you need to know about indications for hyperbarics, and I do think this is something you could be tested on in terms of just like if they're pregnant, they're kind of a unique situation, and so we tolerate less carboxyhemoglobin if you're pregnant. The other thing is if you've got neurologic deficits, you have a seizure, or just really severe symptoms like you're hypotensive, these are reasons why we don't just want you to kind of ride it out on the non-rebreather for a couple hours, but we actually will emergently dive you into the hyperbarics chamber. Okay, so now we have a 6-month-old, comes in, mom is, seems attentive, but, she doesn't vaccinate her baby, and she's really worried. She's like, man, he's just not feeding well, and he seems really constipated. She started preparing his food recently, because she thought that would be healthier, because we want to avoid all of the toxins.
For sure. So what am I looking at then, Jennifer? Because I feel like this is an instance where it's not cool to have just a 6-month-old that presents with poor feeding. Like, what does this baby look like?
Yep. Yeah. So when you're sitting there, most 6-month-olds, they can kind of sit up with some assistance, but you see the baby's kind of doesn't have great tone. Yeah. Mom's having to really support it, even support the head. Just kind of has a floppy head.
Huh. So floppy babies, and this is actually something I'm never, ever, ever going to forget, because one of the smartest people I ever trained with got this case. We do board cases, and he got this case, and it was just like, hey, this is a botulism case. Floppy babies. So, not everybody knows that you can't give honey to a newborn. Yeah. And, it soothes them. It's sweet. It makes them stop crying. But they don't have that, that gut to be able to metabolize the botulism, essentially. They can't break it down. So you get this floppy baby. Such a scary thing. It's something I don't ever want to actually see. But if a baby was originally following all of the, they're growing appropriately, they're holding up their head at 3 months, they're starting to crawl around 6 months, and mom says hey, my baby can't even hold its head up, you really need to take that history of hey, are you putting honey in their food? But not only babies, just from honey, what else can you get this from?
So, any kind of home canned food, so you have to be careful with populations who are getting their food from free or questionable sources. The other thing is that we see this in people who use black tar heroin. And so, adults, you'll, maybe they'll be constipated, but they'll tell you, hey, I'm seeing double. That's always a red flag to me. As somebody, they say, hey, vision changes, and I'm like, okay, is it blurry or are you seeing double? Because double vision, that's a whole different story. You might have some droopy eyelids,
Okay. How do you treat them?
We're going to give them Baby Big.
Baby Big. All right. Now, here's another one, a 2-year-old that comes in, and they are in respiratory distress. They have nasal flaring and retracting. They're altered. They're difficult to wake up. And mom says that she found the kiddo next to a tiki torch lighter, and she thinks that he might have drank some.
Sounds bad.
Yeah.
So tiki torch fluid, this is a hydrocarbon, which there's a lot of different stuff that actually contain hydrocarbons. And so essential oils, people who huff paint or keyboard cleaners, fuel sources like kerosene, all of these can have hydrocarbons in them. And so there's a few components that make these especially dangerous.
That's that whole, and I think this is one of the test questions I had. It's that highly volatile, they're low viscosity, they're low surface tension. That makes them dangerous, essentially, right? It reduces your pulmonary surfactant. That's not a good thing.
No. And the thing about it is, even if they swallow some of it, because it has such high volatility and so much of it can be gaseous, you actually have to worry about pulmonary injury as well. So it's they can be like, no, I swear, I just swallowed it. We have a rule where you actually have to observe them in the ER for 6 hours and then get a chest x-ray at that 6-hour mark.
Wheelchair assistance, ER front desk. Wheelchair assistance, ER front desk.
Sorry, we are recording in the ER, as you can tell, so there may be intermittent interruptions here. But Yeah, so that's the big thing is because they can have kind of a delayed presentation with their respiratory distress, so it's actually a very dangerous exposure.
And unfortunately, it's just symptomatic care. So these are just more like, hey, if you need to protect their airway, you intubate them. You know, the vent's not the treatment for it. It's until your body can heal, until, you know, it kind of is out of your system. So symptomatic care for these patients, there's no antidote.
So here we have a 30-year-old. They come in and they're complaining of some nausea and abdominal pain, kind of have a tender belly, but, you know, nothing terribly focal on exam. As you're kind of going through your history, they mention that recently they tried to overdose. They were feeling really down, but it didn't do anything, and they don't feel that way right now.
Shoot. Well, I'm number one. I have a few questions. Like, what did you try in the past, but it didn't do anything? I'm seeing that you're giving me these abnormal labs. They're very random abnormal labs. So I've got some elevated liver enzymes, and my coags are abnormal. And so as I've been trained, I'm thinking 100% Tylenol. Why'd you do it? That's a bad one.
Yeah. And so this is, I just wanted to point out, you know, like all of these things that you see on here have Tylenol in them. You've got to be kind of careful because all these cold and flu regimens that are on the market, they'll trick you, you know, and now Advil has made this dual action formulation. And so patients like, man, I'm having, actually, one of our guys here, Dr. Lowe, he caught a case that made it through, this is at a different facility, but it made it through the ER into the pediatric ICU. Of a girl that had belly pain, and she was having menstrual cramps, but she had this really weird acidosis and some elevated liver enzymes they couldn't pin. As he was talking to her, she's like, man, I'm just taking Advil, I'm taking ibuprofen for my menstrual cramps, and it turns out she's actually taking a medication that had Tylenol. So she had really severe Tylenol toxicity from this. So I was
Straight back room 12, straight back room 12.
So Tylenol, this is one where there's certain rules with Tylenol. It's if you had an acute ingestion, the only time that it would be helpful for me to get a Tylenol level is 4 hours after the ingestion. If it's chronic and they have, you know, elevated liver enzymes and abnormal coags, or they give you something that you're concerned that they had more than the appropriate amount, you're actually just going to treat these patients with NAC.
They used to make an oral form, which they probably still do. So if anybody ever asks you IV versus oral, always give the IV. The oral smells like rotten eggs. Somebody with an upset belly is definitely not going to swallow that for you. So we just always give the IV NAC, or N-acetylcysteine. Basically, the importance of this that you may need to know for your test is that NAC is kind of a metabolite that's super toxic, and whenever we give them NAC, it helps use a different pathway so that we can break Tylenol down into a more safe metabolite and prevent that liver necrosis.
When we use in the ER, I kind of mentioned that 4 hour mark. The only way it's useful is an acute ingestion, but it's that Rumack-Matthews nomogram. And so 4 hours post ingestion, we apply their Tylenol level to this nomogram, and it basically tells you whether or not they need to be treated with N-acetylcysteine, which is our antidote.
Yeah.
All right, now you have a 49-year-old that comes in through EMS, and they're short of breath and they're nauseous. She's agitated, and she is frustrated because her ears won't stop ringing.
Uh-oh.
She had a migraine recently, and it was just a little bit worse than her typical. So, you know, she's been taking these over-the-counter medications. It's not really helping. She had to take more than normal. And the nurse says that the telly leads won't stick because she's sweaty. Nightmare case.
Bad.
So bad.
So this is making me suspicious for salicylates. The ringing in the ears, the diaphoresis, all of that sounds pretty bad. And so salicylates, like aspirin, or you'll see on here a picture of the wintergreen oil, it uncouples oxidative phosphorylation. So that's kind of the MO that you need to know. So on here, you're going to, again, we can consider bicarb. We've got to alkalinize that urine so that we can get the patient to excrete it through the urinary system. But these can be fatal ingestions.
Yeah, I mean, they're super sick. And so this is one where I think beyond that bicarb for alkalinization of the urine, another thing that we're looking at is like this classic, we're getting a VBG for these patients. And why do I get that? It's like a mixed picture, right?
Yeah, so depending where they are in their ingestion, you know, you'll start out with like a respiratory alkalosis, which then transitions to a metabolic acidosis.
Right.
So if you see that if they're really acidotic, obviously that concerns you that they're a little bit later in the course of things. And so also as they get more acidotic, it increases the CNS absorption of the salicylate, and that's going to kind of promote increasing toxicity. I don't know if it'll be something for you guys to know as medical students or interns, but kind of a unique feature of salicylates is that it will cause neuroglycopenia, which basically means that the glucose in the CSF is low, even though it's normal in the bloodstream. So, kind of odd. Don't hear about it in any other context that I know of. Okay, so this is one that hopefully you guys key off on pretty quickly. We've got an elderly patient that's on some medications, and then he's like, man, can you turn the lights on? Everything is yellow in here, and I can't see.
Yeah, thanks for the answer. The other thing, too, is they'll, like, describe, like, halos around everything, right? These visual disturbances is kind of our classic description in a digoxin ingestion, or not even just injection, like toxicity, right?
Yeah.
So there are some things where you're at the right level, and you'll have classic findings on an EKG, and that is appropriate. And then when you've had too much, or maybe they're still taking their medication like they're supposed to, Jennifer, but they've had like a recent GI illness, and they've had diarrhea, and they've had vomiting, and so that level that they normally take actually becomes a toxic level for them.
Yeah. So here are more plants. And so,
there's a lot of dangerous plants out there. So we've got foxglove and lily of the valley.
Apparently butterflies can give you this.
Yeah, the monarch butterflies.
So this is a medication that it is actually therapeutic for congestive heart failure and atrial fibrillation, and it is still in use. Whenever I first started as an intern, I kind of was under the impression that we don't use this as much, but it actually is within the guidelines for treatment of atrial fibrillation still. It reversibly inhibits the myocardial sodium-potassium ATPase pump, and so what can happen is you can end up with elevated potassium, specifically in acute toxicities. When you see that, that's very bad.
Yeah, very bad. And really the only thing that can treat it, so we have our cigar treatment, right? So calcium and all of that, albuterol and insulin, and do I really want to throw calcium at this patient? For board purposes.
Yeah,
I knew I'd get you frustrated with this one because it's definitely a thing where everybody's like, that's not real. But for board purposes, I'm not going to treat hyperkalemia the way I do for every other patient. Mm-hmm. This is actually when you actually have to give the antidote to treat the hyperkalemia.
Yeah, so we'll give them Digibind.
Digibind. And so what if I don't know the toxic number or how much their ingestion was?
So this is where I will be phoning a friend for my pharmacist.
Right.
But if there's different doses, acute versus chronic.
Yep. And so we're lucky. We have an awesome pharmacist that works with us in the emergency department. And so the other thing is too, I could always call poison control because they do actually give you help, because this is an incredibly expensive medication, and then it's frustrating because it's like following this level after the fact, because any level after you give the Digibind, is just kind of like, I don't know where we're at, right?
Yeah. So this is not something you see too often, kind of a pathognomonic biventricular or bidirectional ventricular tachycardia. Obviously that doesn't look normal, and so it's kind of it's not
pathognomonic, right? But it is something that should cue you into
to what's going on. On this next image that you have, that's more of just the typical digoxin effect. And so we kind of separate it out. Are they toxic, or do they just have like the therapeutic effect?
Mm-hmm.
So there's the Salvador Dali swoops in the ST segments. They're like the hockey stick
right
appearance.
Here. Yeah, so it kind of looks like the end of a mustache. And that's something that you want to see. So that just means they're taking the medication. It's not a toxicity finding. This is just a normal finding when you're on that digoxin.
Yeah.
All right, so now we have a 45-year-old that was found by their spouse. They're unresponsive, and they have multiple pill bottles by their bedside. These is like my probably sickest patient. They have a history of hypertension and depression, and you notice right away that they're hypotensive and they're bradycardic. And I have a patient, anytime they're hypotensive and they're bradycardic, they are a beta blocker or a calcium channel blocker overdose until proven otherwise. Mm-hmm. And then it's kind of like, these patients can be so sick and hard to treat, especially these calcium channel blockers. And you're really giving them a lot of medications just to keep them.
Oh, yeah. They get the kitchen sink.
Yep. Right.
So one specific medication to know in this category is propranolol, because not only will it cause the bradycardia and the hypotension to some degree, but it has some sodium channel blockade, and so it'll be a little bit reminiscent of your TCA toxicity. You'll see their QRS gets wide, they might seize, and so that's one of, we learn about one pill can kill specifically for kids, and propranolol is one of these.
So how am I treating these patients?
So kind of like we talked about, we're going to give them everything, just all that we've got. And so we'll try atropine. It usually fails. If it's a beta blocker overdose, then we can do glucagon. We'll give them epi and, stick them on an epi drip. And we can even try intralipid. But the real thing that you need to know is that whether it's beta blocker or calcium channel blocker is this hyperinsulinemia, euglycemia. So what exactly does that mean? Because I'm kind of confused by that.
You've got me. No, this was actually one of my favorite cases to go over in talks, is they drew up this picture, and I really don't care so much about, you're drawing all of these, like, well, this is where the calcium glows, and why, gluconate works here, and this is where the beta blocker is working at, and so this is why glucagon helps, because it's like this back door. And so, when I was on talks, it was just kind of all this theoretical, like, why does this work? But you're giving them these way higher doses of insulin than you would even like a diabetic in DKA. So you're giving them super high, your nursing staff is incredibly uncomfortable, but you're giving them sugar at the same time with that, so you're not dropping them out. And that's going to treat, interestingly enough, your beta blocker overdose and your calcium channel blocker overdose.
Of course, there's more surgical methods as well that we can do kind of to try to help them. It's like, obviously you see their vitals, 60 over 30 and a heart rate of 30, that's bad. And so we can try pacing, we can try an intra-aortic balloon pump, we can try ECMO. But ultimately, sometimes these patients do die because they're bad. And,
we don't have ECMO here at our facility, and so the last one that we had of these was actually a co-ingestion of both beta blockers and calcium channel blockers, which is incredibly unfortunate. And you just have to, you have to keep them alive to get them to ECMO if you get them accepted, right? So, and a lot of times when you go and you're trying to either transvenously pace them or transcutaneously pace them, it doesn't actually work because there's not a lot of calcium in there, for you to get that squeeze, that heart squeeze. So we're throwing calcium and glucagon and epi, we do all of this, but it seems like the hyperinsulinemia, euglycemia helps a lot.
Yeah. Well, you guys did great. Hopefully you've made it to the end of all of this rambling, and hopefully you're able to find it helpful. Kind of just to summarize, like we mentioned, ABCs always look at your patient, start at the top, airway, breathing, circulation, because if their heart's not beating, it doesn't really matter what kind of toxidrome they have.
That's a good point. You want to be able to get to be a detective, but if you didn't get your primary survey or you secure the patient and you're stabilizing them to get to that point to do detective work, then what's the point? Yeah. So the other thing, and Jennifer talked about this a lot, is sometimes we have 20, 30 people in the waiting room, and we just have all these stray backs and this really sick patient population, and we're just in a hurry. But don't ever be so much in a hurry that you're not reviewing the med list and getting as big of a history as you can, because they'll always, a lot of patients can tell you what's going on with them, or they will if you stop and you take the time to listen to them. Or if you use family members in the room and get a history, because that makes these tox things a lot easier. And otherwise, it's just that, hey, always get a finger stick. That's a board question of why someone could be altered, or are they hypoxic? Give them oxygen. You can fix a problem. Give them thiamine. Give them Narcan. These are all things we can do without harming the patient. That can give us a lot of answers. But really, that history and that med review, it can't be overstated, I think. So. Yeah. All right. And here are some the resources. Tintinales is our main book in the emergency department, but Up to Date and Core EM, Life in the Fast Lanes, one of my favorite sources to go to for learning EKG stuff, but they have a lot of other good things as well. So anyways, thank you for your time. I hope this is helpful. Please give us feedback as to how we can improve. Thank you.